put them on Blackboard for you. Anyone in the class seen an MRI, had an MRI, know what MRI is about? Oh, what am I doing here? So seen it or had it? Okay, so what did you notice about, what are the things that stood out when you had an MR exam? Noisy. They asked you lots of questions before you went in there, whether you got things inside you and whatever else. Took a long time. Get claustrophobic, get hot. Okay, let's try and work out what happens when you have an MRI scan. Anyone from Nuke Med here? What do you guys know about MR in Nuke Med? Are you familiar with PET MR? So there's now hybrid machines being made that sort of merge the two technologies together, so PET MR is a thing. So, you know, characteristically what people say is, what am I learning about MRI if I do Nuke Med? Well, there's a chance that when you go out and practice, maybe not tomorrow, but in time to come, you'll be exposed. Like, there'll be people that will have to understand how both modalities work, because you might be driving a PET MR machine. RTs? You guys come across MR much in RT? So there's a job currently, actually it's probably been filled now, but there's a job going in the radiation oncology department at Calvary Mater for an MR radiographer. So they're looking, so MR is becoming more used in RT. So, you know, RTs can acquire their own CT scans, and they're now getting to the point where they'll be starting to acquire their own MR scans. So MR is being used more and more for planning. When you get into sort of later stages, you'll realise that, for instance, if you look at a prostate on CT, you kind of see like an organ, a mass. When you see it on MR, you can definitely understand a lot more of the structural integrity, and you can see isolated lesions. So you might be using that to say, I'm going to treat the whole gland with this amount of radiation, but I'm going to give a boost to these isolated lesions that I now know are prostate cancer within the gland itself, that you can see on MR that you don't necessarily appreciate on CT. So now there's a big move towards a lot of contouring for radiation therapy planning occurring on MR. So what I'm just trying to say that, you know, MR is now being used more across MRS than it has previously. And once upon a time, if you thought, well, I do Nuke Med or I do RT, what do I need to know about MR for? It's because if it's not currently in your job description, it will be in years to come. And, you know, I kind of use the example that when I went through this course and learned about MR, one of the things they used to tell us was that, you know, MRI can't do bone, can't do lung, can't do heart. Well, it does all of those things now. So it's not just what you're going to do when you go out and practice when you graduate, it's what you're going to see as your career develops over time. So what I'm going to do is just start with like a really simple overview of what MR is, and just these couple of really simple steps. So the first thing that happens is the patient gets placed in a magnet. So, you know, you go into the room, you've been screened to make sure that you don't have any metal inside you, which could be a contraindication for having an MR scan. Then you're going to be placed on a table. Table's going to come up, and then you're going to slide inside the magnet. So the magnet is that sort of tunnel, is how we mostly sort of think of it. It's that tunnel that you go into. And that tunnel's normally described in terms of Tesla. So that's the unit that we think about for magnetic field strength. And in Australia, most magnets that you go into are either going to be 1.5 Tesla or 3 Tesla. Once you go in there, a certain percentage of the patient's protons, so protons inside us as patients, will be affected and will align with that magnetic field. So what we do is we're perturbing them from their ground state to align with the magnet, and that's probably the critical thing. Once we perturb something, we can interfere with it. So we can interfere with it and then excite it, wait for that excitation to be given off, and that's essentially what we record as our MR signal. So once the protons start to align with the scanner magnetic field, they're inside the imaging bore. We use radio waves that are transmitted from the scanner to perturb those protons, and that's the noise that you hear, or most of the noise that you hear, that sort of banging noise that you hear when you're in the scanner. That's the gradient operating and RF transmitted. Once we turn that radio signal off, and it really only turns on for a matter of milliseconds, once we turn that off, then the energy that those protons have acquired, it's given off, and that's what we detect as our MR signal. And that signal that we detected, we just do some sort of funky mathematic stuff with it, and that gets reconstructed into the image. So we do Fourier transforms once we know where the signal's coming from, and that's essentially how it works. Okay? So just in more detail, as I said, we put the patient inside the scanner. When we talk about MR, you need to understand just a couple of really simple concepts around atoms. So an atom has a nucleus and an electronic shell. So if you'd understand those things, then you understand what a proton is, a hydrogen proton, as opposed to, say, trying to image carbon within the body, which is possible, but when we talk about clinical MRI, it's all about imaging protons, or basically the spatial distribution of fat and water. So in the nucleus, we have these little things called protons, and a proton has a positive charge, so that's the other key point. So these little protons are kind of like little planets spinning around. So it's a particle, it has a charge, and when it spins, it has an associated electric current. So they're constantly turning, they're spinning around their central axis. In MRI terminology, we talk about this as them possessing a spin, and that word spin will come up a few times. We talk about spin density imaging, for instance. As I said, they've got a positive charge, so that charge is also spinning, turning. And you might remember that if you have a moving electric charge, then you've got a charge that's moving, then you've got an electric current. So that's the other thing that we need to remember. And if you remember, you've probably seen that experiment where people get an iron nail and wrap a wire around it and then connect it to a battery and it turns into a magnet. That's essentially what we're doing with an MRI scanner. That's partly how we make our magnet, but inversely, if we have a magnet and we move it through an electric field, then we get a current. Okay? And that's what our MR signal is. So where there's a moving electric current, there's also an associated magnetic field. And that's kind of, just a little pictorial how it looks. If we just think these are our protons, they're turning around, they're spinning, so there's an electric charge. Just think of it as being a magnet. Okay, so all those little protons that are inside us, once we put a patient inside a magnet, all those protons that we affect can be added together to what we call as a net magnetization vector, and that's what we're working on when we do our MR imaging. So just to review, proton has a spin, it's also got an electric charge that's spinning around. That moving charge has an electric current and an accompanied magnetic field. So each proton, in a way, is its own very small miniature bar magnet. And it's the addition of all those little bar magnets from protons inside us which allows us to do MR. Just to go into a little bit deeper, when we look at those small protons inside of us that are the little magnets, if we kind of think about if you take a compass needle and put it somewhere, it can only point in one direction. So these little protons inside of us that are affected by the magnetic field can have two states, state up, state down. One has higher energy than the other. It's the difference between the high and the low energy states, which is what we work with. The reason that's important is because the higher the magnetic field strength, the more there are that we can use, so that distribution gets distorted. And that's why you'll see that most imaging now, so when MRI first started, people used to image at about 0.2 Tesla. As technology changed, we were able to develop magnets of stronger magnetic field strength, such that most installs now, brand new installs now, are 3 Tesla. The reason for that is because the higher the magnetic field strength, the higher the inherent signal to noise. And what that equates to is us being able to image areas that have poor proton density. So things like lungs that used to be quite difficult to image, we now can. Means that we can image faster because we've got more signal to noise. And it means that we can do things that previously we couldn't do that are quite SNR challenged, like spectroscopy, for instance. Okay, and as I said, this is protons sort of outside of the body, away from a magnet. So this is all these protons inside of us, outside of a magnetic field, are just randomly distributed. As soon as we go near a magnet, we start to see alignment. As I said, we will get some that will align with the field and some that will align anti-field, so spin up or spin down. And it's the difference between these two groups which allows us to do our imaging. So in this case here, it's a difference of 1. Okay? And when we think about all those literally billions and billions of protons inside of us, we can represent that as a vector. So this is our net magnetization vector. As I said, the reason that we do imaging with protons, so here's our hydrogen, H1 is a proton, is because it has a really, really high natural abundance. And not only that, about 85% of us is made up of water and fat, so lots of protons. In theory, you can do imaging on anything that has an odd number, which means it has a net spin. So you could do carbon-13, nitrogen-15, sodium-23, etc. And some of these are used for imaging, but not routine clinical imaging, like the sorts of scans that you guys that said that you've had an MR, not those sorts of scans. These are really more research things. Okay, so that's any questions about that at all? I know that it's a big jump to sort of go from walking through the door to now we're talking about quantum physics, but that's how MR is. And if you understand some of those basic principles, then it'll make it a lot easier to kind of understand what's going on in the processes. So any questions? All right, we'll jump into what you now have as your lecture notes. As I said, I'm happy to give that to Helen and she can stick it on Blackboard for you. I'm delivering this lecture for Helen. I'm Peter Stanwell. I'm in medical radiation science. I'm, like you guys, a radiographer. It just so happens that I've been working in MR for about 25 years. So at the end of this lecture, we're going to, hopefully you'll have a basic overview of what MR imaging is. Hopefully we'll be able to discuss some of the advantages and disadvantages of MRI. And we'll be able to describe how a proton in the body acts like a magnetic field. So we kind of spoke about that already. We'll discuss the effect of an external magnetic field on a proton nuclei. So we've spoken about that a little bit already. All those protons, when it goes in the magnetic field, will have some align with and some align against the field. And it's the difference between those two states, which is what we work with. Describe the two energy states. We've just spoken about that now, some aligning with and some against. And then it's the addition of all those protons that we think about as being this net magnetization vector. We'll describe precession. So precession is really the spinning, these protons inherently spinning inside the main magnetic field. And there's an equation that links them called the Lamar equation. For anyone that doesn't know it yet, I love equations, but I will only ask you to know one, and that's this Lamar equation. And it's pretty simple. You'll see it in a minute. Describe the effect of an RF pulse on an individual proton and the net magnetization vector. We'll get to that. and we'll discuss briefly what T1, T2, and refer to this little guy down here as T2 star, what they mean. So anyone that's had an MR examination on themselves has had T1 and T2 images acquired of whatever body part it was that they had examined. Depending on what it was, they may have also had T2 star. Okay. The main reason, the real power of MRI is really this idea of contrast resolution. So it's really good at looking at soft tissues. So for instance, if we do an MRI of the knee, we can see things like the bones, we can see the menisci, we can see all the ligaments, we can see ACL, PCL, so anterior cruciate ligament, posterior cruciate ligament, collaterals, all those things. We can see different muscles and we can differentiate different muscles. And within muscles, we can see tendons, etc. So we're really, really good at looking at contrast between different body types. It's a good choice. It's for looking at the brain. So in the brain, for instance, we can quite easily see the difference between grey and white matter. We can pick up things like cranial nerves. Really good at looking at cancers. Great for doing cardiac studies, and I've worked at places where they have magnets that just do cardiac exams all day. That's all they do, is just MR of the heart. Used in radiation therapy for treatment planning. So as I said, if you're looking at the prostate on CT, you can kind of see it as a gland. When you see it on MR, you can see the difference between peripheral zone and transitional zone. And when you get to know a little bit more about prostate cancer, you'll know that about 70% of prostate cancer exists in the peripheral zone as opposed to the central. And those that are in the peripheral zone characteristically are more aggressive and are the ones that are going to be more deadly than the ones that are in the central. So when we, for instance, identify cancer, prostatic cancer in the central gland, there's an ongoing argument that these are the guys that we don't necessarily need to intervene with a lot. We can just subject them to what we call wakeful watching, which is just not necessarily giving them the full-blown cancer treatment, but watching them over time and seeing what their cancer does, and maybe not having to submit them to high levels of radiation treatment or chemotherapy. There's actually a series of where they've looked at autopsies of men that have died, and at post-mortem what they find is that a lot of guys that die in their 80s die with prostate cancer but not from it. So there's an argument that just because we know they got cancer doesn't mean that we need to do much about it. As I said, the human body contains literally billions and billions of hydrogen protons, and this is where we get our signal from with MR. As I said, we get a patient, we place them in a strong magnetic field, so that's the scanner, the tunnel that they go into, and as soon as we do that, a proportion of their protons will align with the external magnetic field associated with the scanner. The magnet provides that source of magnetic field to align those protons. Magnetic field, like the magnet that we talk about as itself, we talk about that in terms of just notation as being the external or main magnetic field, and in nomenclature we talk about it as being B0. So B0, when we talk about something being B0, we're talking about the magnetic field strength of the scanner, so that 1.5 or 3 Tesla. So protons are aligned in the main magnetic field, and then we can move them out of alignment by applying radio frequency pulses. That, as I said, one of those banging noises that you hear when you're in the scanner is the application of these radio frequency pulses. Does anyone familiar with this idea of radio frequency pulses? So in MR, like at 3 Tesla, those radio frequency pulses characteristically, we talk about them as being 123 megahertz. And if you ever go and look on your FM radio dial, you'll see that it goes from about 90 to about 114 megahertz. Anyone that's had an MR scanner, do you remember when you went in the room, there's a dirty grate door that they would have closed when they went out? So that door, the job of that door is to exclude radio frequency sources from outside of the room going into the room and corrupting the image. So we think about MR as being, so it doesn't use ionising radiation. That's another great reason to have an MR exam. No ionising radiation, but it does use electromagnetic radiation in the form of radio frequency pulses. But what I'm saying is that the characteristics around those radio frequency pulses are not too dissimilar to what we're exposed to in the environment 24/7. And the idea when you go in that room and they close the door, as I said, is to exclude those radio frequency pulses from entering the room. As a matter of fact, it's a really nice experiment. If you have a radio, turn it on, go inside the room and close the door, the radio will no longer work because it can't pick up any of those signals. So the room is enclosed by what we call a Faraday cage, which excludes all of that signal. So if you go and sit in an MR and you look through the mirror, you'll notice that it's got mesh, and it's kind of like the mesh in a microwave, in the door of a microwave, and its whole purpose is to exclude those signals. So the frequency of the radio frequency pulses causes the protons to move out of alignment. So we're giving them energy, we're giving them more energy than they have at their ground state, which means that they will start to flip away. So if they're all aligned with the main magnetic field, what you'll find is that they start to flip over to the 90 degrees. And we can control how far they flip. That's controlled by the person running the scan, the radiographer. The more you flip them into that 90 degree, the more energy it takes and the more signal we get back that we can use. Key point is that we only affect protons that are at the resonant frequency move out of alignment. So that's how we kind of work out where our images are being acquired from. So as they're out of alignment protons, so those that we flipped away from the magnetic field move back into alignment, they'll emit a signal. So the energy that we've given them, they now want to give it off. And that signal that we detect, that's how we make our MR images. The strength of the magnetisation depends on the presence of the magnetic nuclei. So this is why hydrogen is used, because it's really abundant. So there's heaps and heaps of hydrogen inside us as humans. The level of magnetisation existing at a certain time determines the image brightness. So when you look at an image on a screen or on a piece of film, what I'm saying is that the level of magnetisation will determine what sort of grayscale we see. So if you think of, say, looking at a chest scan, obviously there's not a lot of magnetisation in air-filled lungs, as opposed to there being a lot more magnetisation in the heart, because there's just more protons there. Direct measurement of the tissue magnetisation is not possible, so it's inferred indirectly. I guess what Helen's really saying there is that we don't actually measure the decayed signal straight away. We have to do a few things to it. So we have to create what's called a spin echo, which will come up in lectures later on. But the important thing is that a single atom does not generate a large enough signal to be observed. It's really all of those protons acting together as this net magnetisation vector. So the signal measured on an MR system is really the combined signal of billions of atoms. So anything that we can do to make that, to enhance that process, and the most common one is higher magnetic field strength, the better the quality images. So what you'll find now is that basically every New South Wales hospital that wants to put in an MRI scanner is basically dictated by the government that it has to be 3 Tesla, because that's now the new standard because of the enhanced signal to noise ratio. Better quality images, less imaging time, etc., etc. So let's just talk about advantages and disadvantages of MR. So we have high contrast sensitivity to soft tissue differences. So MRI, so the concept of MRI has really been around since about the 1920s, when people realised that they could work out the chemical structure of unknown compounds by putting them inside a main magnetic field. So that had been known about for years. in sort of the late 1970s and 1980s, a guy called Damadian realised that if he looked at a tissue that had a tumour in it, that the tumour tissue and the surrounding adjacent normal tissue had different T1 and T2 relaxation times. And he had the idea that if he could actually make a map of that, he just invented a new imaging modality, and that's essentially what happened, and he got the Nobel Prize for that. So that's how MR came about, the fact that tissues that have been transformed into tumours have a different T1 and T2 relaxation time. So this concept of contrast resolution. And that's really what made MR such a valuable tool, that we can see cancer and normal tissue and differentiate between the two with very high sensitivity. The other great disadvantage, as I said before, there's no ionising radiation. So it makes it really good for research. So I do a lot of research in sports concussion. So I look at athletes that have had concussions and measure them at baseline, and then after they've had their injury, and then when we want to return them to play. And we can do that with high level of confidence, knowing that we're not exposing them to ionising radiation. So MRI is considered to be reasonably safe, or very safe. There's no known side effects from being exposed to the kinds of magnetic fields that we use in imaging. Some people will experience noise, claustrophobia, maybe heating, but none of that has been shown to have any lasting effect. Disadvantages are really high equipment and siting costs. So an MRI scanner can cost upwards of $2 million, and then the site preparation can also add to that. So these things tend to weigh, well, really high level fields like 7 Tesla can weigh as much as 40 tonne. So you've got to do a lot of site preparation. Faraday room, the Faraday cage can cost you a couple of $100,000. Scan acquisition complexity, so they're reasonably complex systems, but once you've been scanning for a while, it's pretty easy to do as a radiographer. Someone already said that the scan times are quite long. You can get image artifacts. So for instance, if you're trying to scan someone that's got a hip prosthesis and you're being asked to do an examination on that same hip, it's not going to work because the metal that's part of the hip will cause issues. Patients can be claustrophobic, and you will find people that really find it quite difficult to have an MR scan. So one of those is really little kids. So what you'll find is a place like John Hunter actually does 2 sessions a week where they put kids, they have general anaesthetic. So they put kids to sleep inside the scanner so they can have their scan done. But they're doing that because they know the information that they get is not available through other means. And there can be certain implants which can create issues, and the main one that we think about is cardiac pacemakers. And there have been instances where people have gone in the scanner with a cardiac pacemaker and died as a consequence of that not being detected before they went in. So that outcome is pretty severe. As I said before, these are the sorts of contrast resolutions that we can get. So proton density, we've now just made an image based on the number of protons in the body. So what I'm showing you here is, here's a brain scan, and all this stuff on the outside is grey matter, and all the stuff on the inside is the white matter. And that's really important for things like stroke, because you can have a stroke which will take out quite a large percentage of your grey matter. It will be infarcted and dead, and you can still exist, reasonably well. You only need to lose a very small part of your white matter, and that can have some quite severe complications post-stroke. You may lose your capacity for speech. You may lose arm movement. So, as I said, MR is really good at being able to differentiate between this sort of surface grey matter and deep white matter. And again, you can see it on our T2 weighted scan. Here's our grey matter and here's our white matter. Now we can quite easily see the CSF within the lateral ventricles. And things like this, these are really small perforating vessels. We can see those nicely on MR also. And this one's T1 weighted, and over here this is what we refer to as magnetic resonance angiography. So we can make angiographic type sequences of the brain without having to inject any contrast media. We just manipulate the scan to be sensitized to flowing blood. So, yeah, you can see all his anterior cerebral artery, for instance, which we can nicely see without having to inject anything into the brain. And then we can see venous structure at the back here, for instance. We see venous blood within the straight sinus. So protons in the human body act like little magnets. So as I said, you know, we just think about all those protons as sort of being little individual magnets. So a material is considered to be MR active as long as it has a mass number which is odd. This is this concept of going back and just quickly telling you about, you know, remember what atoms are made up of: protons in the centre, electrons in the outside. So if it has an odd number, it's got a net charge. So if it's a net charge and it's spinning, then there's an associated magnetic field. So we're really looking for things that have that odd number, protons being hydrogen 1, as opposed to we can't do anything with what's called deuterium, which is hydrogen 2, which is an isotope of the normal hydrogen. Nuclei that have a net charge and are spinning acquire this concept of a magnetic moment. So if they're all tiny little magnets, then we can interfere with them. And as I said, the nuclei will align their axis of rotation to the external magnetic field, so the scanner, essentially. And remember I said, just think of that whenever you see this B0 term, it's really referring to the applied magnetic field. And again, just kind of giving you a concept, this is our spinning proton. If you ever remember, if you've ever done that experiment where you get a little magnet, put on a piece of paper and then tip iron filings on it, you'll find that they form a pattern like this, and these are our flux lines. So just think about all those protons as being tiny magnets, add them all together. As I said, they're spinning, that's our magnetic moment. So that magnetic field that's spinning around inside the magnet. Why do we use hydrogen? So as I said before, it's a single proton, a mass number of 1, which means it has a spin, and it has a relatively large magnetic moment, and water makes up about 85% of the human body. So just what that tells you is there's just stacks and stacks of protons inside of us, and that's why clinical MRI is done on protons. As I said, so here's our natural abundance. So remember I said that you can get hydrogen in other states, you can get deuterium and tritium, but they're really rare. Very high natural abundance for protons. There's also a really high natural abundance for phosphorus, P31. As you can see, it's about 100%, but look at the sensitivity, it's about half of what hydrogen is, which is why clinical MRI is really done on protons. In saying that, there are studies that people look at P31 for energetics, so this whole concept of ATP, which is all about how cells are powered. You can do phosphorus spectroscopy on muscles, for instance, and get a really good idea about metabolic disorders of the human body. The clinical MR that radiographers like you guys will be doing is all done on protons. So what's the effect of a proton going in that magnetic field? Remember I said before that in the absence of a magnetic field, all those protons are just randomly distributed. As soon as we take protons and put them inside the magnetic field, so as soon as we take us and put us in a scanner, we tend to find that these protons will want to align either with the field or against the field. And it's the difference between those aligned parallel and those aligned anti-parallel which gives us the signal that we can work with. Okay? As I said before, these hydrogen nuclei can possess two states. You can have those that align parallel with the field, and we call those spin up, and we can have those that align against the field, and we call them spin down. But it's the difference between those two which is what we work with to make our images. There is an equation that links that, it's called the Boltzmann equation, and in that Boltzmann equation there is a term for basically magnetic field strength, which is what I was saying before. why there's been a move to have higher and higher magnetic field strength. There is a theoretical limit as to how high you can go, and in the last few weeks there was a magnet opened up in Minnesota at 10.5 Tesla. People that go in a 7 Tesla scanner, and there's 3 of those in Australia, experience a lot of physiologic effects. So for instance, you get photoscintillations. You're lying in the scanner doing nothing except lying in there, and you're seeing flashes in your eyes because that magnetic field's starting to interfere with your optic nerve. But that's not what we image with. We characteristically image with 1.5 or 3 Tesla. At any given moment, there's always going to be a very slight majority aligned with the field. So this is this concept difference between the two states. So that very slight majority is what we work with to make our imaging. So a larger magnetic field, you see a larger difference. So this is what I was saying before about why there's been a move to get a higher magnetic field strength. And that's important because that's our signal to noise ratio. And any time we can increase our signal to noise ratio, we can translate that into higher resolution imaging and shorter examination time. And when you've got someone that's claustrophobic, or you've got a child that you've put to sleep with a general anaesthetic, you always want to image as fast as you can. There's always an inherent risk in having a general anaesthetic, so you want to scan as fast as you can so that the kids are only put asleep in there for a limited amount of time. So just use a rough example. If we think about 1 Tesla, basically for every 2 million protons, there's about 6. That difference between high and low is about 6 protons, but as I said, there's literally billions and billions of protons inside of us, so signal to noise is never really an issue. We kind of think about that as being quantum mechanics, where we're talking about individual protons. When we talk about vectors, that's more classical mechanics. And people will flip between the two when they're talking about MR. So if you just understand that when people are talking about individual spins, that's quantum mechanics. When we talk about vectors, or we show arrows, such as this, that's classical mechanics. We're talking about the sum of all those individual protons. So the net, or the sum of all those individual protons pointing in the direction of the magnetic field, act together. So it's the sum of all those that gives us the net magnetization vector. So what this image here is showing is, here's our main magnetic field, our B0. We have some protons that are aligned this way and some that are aligned that way. We think about the difference and we represent that difference as the net magnetization vector. So in the longitudinal axis, this is the axis that we characteristically think when we put someone in a scanner. The longitudinal axis would represent, if we were that arrow would align with the human body. So think of, an arrow that passes from feet to head. So that's our longitudinal axis, and our transverse axis is just perpendicular to that, 90 degrees. So when we put someone in the scanner, we have a lot of magnetization in that direction and not much in that direction. What we want to do is take some of this and flip it with the application of our radio frequency pulses over to here. So we give them energy. As soon as we take those radio frequency pulses away, they go back to align with the main magnetic field, back to their ground state. And when they do that, they give off a signal, a radio frequency signal, and that's what we detect for our MR. Okay, so just again, this is just a few little conventions talking about the component parallel to the main magnetic field is called the longitudinal magnetization, and sometimes denoted by this idea of MZ, so Z being the longitudinal direction. And in our transverse plane, if we flip it 90 degrees to the main magnetic field, we talk about that as just being in the XZ plane, or MXY is our transverse plane. Don't think you're going to get tested on that. It's just terminology. In case you're doing any further reading and come across those terms, you know what they mean. So factors affecting that net magnetization vector I've already mentioned before. The main one that we are interested in is magnetic field strength. in theory, if you look at that Boltzmann distribution, it also has a term in there for temperature. So if we were to heat people up, we could make more signal, but I can tell you that's a really bad thing to do. You've only got to disturb someone's temperature by, a very small amount, and you will make someone extremely sick. If you make them a couple of degrees warmer or a couple of degrees colder, not good. So changing temperature, not a good idea. So patient temperatures cannot be significantly altered. So really what we're looking about is this idea of just putting them in a stronger magnetic field. And there's always been this move to create magnets which are stronger. That just has to be balanced off with bioeffects. Okay, important terms. So magnetic moment of hydrogen, protons, in the case of clinical MRI, is called the net magnetization vector. So we spoke about that a minute ago. The static external magnetic field we refer to as this term of B0. So every time you see B0, we're really just referring to the strength of the magnetic field. The interaction between the net magnetization vector and the B0 is the basis of MRI. And we talk about scanners as typically when we describe an MRI scanner in a hospital, we're talking about it as having a magnetic field strength of Teslas, not so much Gauss. 10,000 Gauss is 1 Tesla, okay? So if you go into a department, say, what magnet have you got? They'll say it's a 1.5 Tesla or a 3 Tesla. Precession. So the idea of precession is really just, as I said, what happens with these tiny little magnets is when they go in the magnetic field, they spin around. So what we're seeing is they're wobbling. So we see our little proton aligning with the field, but it's also mapping out this circular path. So there's our circular path. If we could sit there and look down on top of it, it's a circle. The reason that's important is, number one, we describe this movement as precession. The other thing is that we'll talk about things as being in phase and out of phase, and we'll get to that in a moment. And that's this idea of like moving around this circular path from the top. So we call these little spins as precessing, and this is going back to this Lamar equation. I said if you only want to learn one equation, it's this one. So precessional frequency is the frequency at which, so how fast that net magnetization vector wobbles or spins around the external field, the B0. So the precessional frequency is calculated from the Lamar equation, and this is the Lamar equation down here. So this is our precessional frequency is equal to the magnetic field strength and then the gyromagnetic ratio. So every tissue type will have a different gyromagnetic ratio. So that's how we are able to tell the difference between grey and white matter. Remember, before I said this idea of we talk about 1 megahertz is 1 million cycles per second, and I said that 1.5 Tesla operates at 63.86 megahertz, and 3 Tesla operates at 123, and that's kind of not far outside of the realms of FM radio. It's also in the realms of things like remote controls, etc., things that make your garage door go up. So you can calculate the Lamar frequency or the precessional frequency by knowing the magnetic field strength and the gyromagnetic ratio of the tissue that you're examining. And again, as I said, gyromagnetic ratio is just specific to tissue types. So that's how we can tell the difference between grey versus white matter versus CSF, for instance. And as B0 increases, so does the Lamar frequency. And you can see that, in this term here. If we increase this term, then this goes up. That's all that's saying. Okay, what's the effect of a radio frequency pulse? So MRI stands for magnetic resonance imaging. So we already know where the magnetic bit comes from. The resonance comes from this idea, and the easiest way that I can explain it is this concept of a tuning fork, which I think might be shown there. So if we had a whole bunch of tuning forks and we have 2 that are tuned the same and we strike one, only one of those will resonate with the same frequency, so they're matched. So what we're saying is that resonance is the absorption or emission of energy only at certain specific frequencies. So here, if we have an E tuning fork, and over here we've got a bunch, and we strike this one here will resonate because it's tuned to the same frequency. Okay, so because they're the same frequency, it's able to absorb those vibrations. So the application of an RF pulse, again that noise that you hear when you're being scanned, the application of an RF pulse causes resonance to occur, and we talk about this as excitation. Remember I said that when we fire radio frequency pulses in, we perturb some of those protons away from the main magnetic field. This is this idea of excitation. We're giving them energy, we're exciting them. As soon as we take that RF away, they want to give that energy off, so they emit it, and that's what we detect as our MR signal. So this absorption of energy causes an increase in the number of spin down, an increased number of spins at a higher energy state. So just think of it as that sort of example of the matched tuning forks. So that's our resonance part. Once the RF transmitter is turned on, three things begin to happen simultaneously. Number one, RF energy, so that noise that we hear is being absorbed, but only at those at the resonance frequency, and we'll get to that later on. So those excited protons are flipped away from the main magnetic field. So I was talking about this concept, that's our main magnetic field, our BZ, our B0, and we talk about our MZ, our net magnetization vectors being in the Z plane. When we energize them, they want to flip over into the XY plane, and that's our magnetization XY. So once we do that, we've energized them. As soon as we take that away, they'll give that energy off. So excited protons are flipped away from the longitudinal, so aligning with the field, away from that alignment. And these excited protons begin to spin in phase. That's a slightly harder concept, but remember I said they're all spinning around. If we look down on top, it's a circle. What I'm saying is that when we energize them, they will all go to exactly the same point on that precessional path. So that might be, think of it as a watch face, they all go to 3 o'clock. As soon as you give them energy, they will all go to 3 o'clock. That's important because as soon as we take that energy away, they all want to speed up because they're different tissue types. Might be muscle, might be tumour, might be bone. They will all be moving because of that gyromagnetic ratio term. They'll all be moving at a different point in time. And it's that loss of phase which becomes really important as a contrast mechanism. As I said, we'll get to that. So this is this concept of out of phase. Remember I said if we thought about looking at them down on from the top, it's a circle. See how we've got here where you could describe that as kind of being close to 6 o'clock, this one's close to 7, this one's close to 1, this one's at 3. So this is out of phase when they're just randomly moving around, and this is where we've now hit them with RF pulse and they all go to in phase. So they're all roughly at that 3 o'clock position. So this is out of phase, they're randomly distributed. In phase, they're all at the same point in time. Okay, so two important things. Point after the application of an appropriate matching frequency. So this description of an appropriate matching frequency is really this concept of resonance that has to be at exactly the same frequency or pitch if we're thinking about it as tuning forks. So the excited protons are flipped. So you'll come across this term, they're flipped away from the longitudinal direction, so aligned with the field. We flip them away into the transverse plane, so from here to here. So we're flipping them away. The excited spins, the protons begin to spin in phase. So we went through that, this idea that they're all at the same point on that circle, that circular path. And the individual moments are in the same place on the precessional frequency. So what happens is our vector would be pointing here, we flip it down into the XY and this is just describing how the pulse is applied, and then they start to fan out around this precessional path because they're not all the same. We're made up of different sort of tissue types. So the degree at which they fan out is what we use to make T2 weighted scans. And that T2, we think of those T2 weighted scans as being kind of the pathology scan. We think of T1 as being the anatomy scan because it has high signal to noise, really good for looking at anatomy. T2 tells you all about pathology. So as I said before, for resonance of hydrogen to occur, that RF pulse has to be matched to the protons that we want to affect. So this idea of resonance, and it has to be matched in terms of the Lamar frequency, that equation that I showed you before, precessional frequency equals gyromagnetic ratio times field strength. Okay, so it has to be matched. And I said before that a hydrogen proton in a 1 Tesla field is basically at 42.58 megahertz. So at 3 Tesla, we're talking about, this sort of 3 times that, 127. What you tend to find is they're more 123, which is about 2.9 Tesla. I don't know why they make them at 2.9, but every magnet I've seen is 123. The resonance. At resonance, the net magnetization vector moves away from that B0. So this is our alignment with the main magnetic field, and when we hit it with that radio frequency pulse, depending on how strong it is and for how long it lasts, we flip it over here to this transverse plane. So we're going from this to this. So flipping it 90 degrees, okay? The angle at which it moves is called the flip angle, and this is controlled by the pulse sequence and hence the person driving the scanner, the radiographer. The magnitude of the flip angle depends, as I said before, depends on the amplitude or the power of the pulse and the duration. So that duration, it's not seconds, it's micro to milliseconds is how long we turn it on for, which is why you hear that thump, 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 thump noise when you're in the scanner. It's all these radio frequency pulses turning on and off really rapidly. The one that we talk about and the one that's simplest to explain is a 90-degree flip angle, which is where we just flip those protons 90 degrees away from the main magnetic field. So again, here's our B0, which denotes our applied field or the strength of the scanner. What we want to do is we just want to apply that transmitted RF pulse strong enough and long enough to flip it 90 degrees. So we flip that net magnetization vector, and remember that net magnetization vector is the sum of all the protons inside of us minus the difference between spin up and spin down. It's the sum of all of those. So we now rotate it into the transverse plane. And remember, a couple of things happen. We start to move them into the transverse plane and we have phase coherence. They're all in phase, they're all at that same point around the circle. So the phase is the position of each magnetic moment in that precessional path around B0. So when resonance occurs, all the magnetic moments move to the same point, and I showed you that before. They all go to that sort of 3 o'clock position if you want to think of it as like that. But the important thing is that they're all at the same point in time. So that 90-degree RF pulse produces phase coherence of the individual spins and generates a maximum possible transverse magnetisation. So now we're kind of getting to the guts of it. When we hit it with a 90-degree pulse, we put a high proportion of them into the XY plane. They're in phase coherence. Now, if we start to monitor how they give that signal back and relax back into alignment, those two terms will give us our basic MR signal, T1 and T2. So as the net magnetisation vector rotates at the Lamar frequency, the receiver coil, which is what we're doing their imaging with. So if you're having a head scan, it's the coil that goes over your head. If you're having a knee scan, it's the coil that goes around your knee. It detects this rotating net magnetisation vector as a receiver, and that's the MR signal that we ultimately reconstruct to give our images. So our MRI signal is greatest when we flip it into the transverse plane. So I spoke about a 90-degree pulse. There's lots of other imaging that you do where you don't necessarily use a 90-degree pulse. The main reason why you don't want to always use a 90-degree pulse is just time. It takes longer to do it. So you can do what's called gradient echo imaging faster. If the magnetic moments are not precessing entirely within the transverse plane, the signal is reduced. So that's what I'm saying about 90 degree will give us our maximum signal, whereas if you're doing gradient echo imaging, you might have a flip angle that's only 15 degrees. You automatically don't have as much signal to noise, but the reason to do that is speed. If the magnetic moments are in the longitudinal plane, there's no signal. So if we don't perturb them, if we don't flip them away from the alignment with the field, we've essentially got no signal. So without the application of RF pulses, we have nothing. The amount of magnetisation in the transverse plane is responsible for the MR signal. So again, just saying that the more magnetisation we flip into the transverse plane, the higher the signal to noise. Once the RF transmitter is turned off, three things begin to happen simultaneously. The RF signal is retransmitted, so it's given off because it's now got excess energy. It doesn't want to have that excess energy, it wants to give it away, so it retransmits it. The excited spins go from that point in the transverse plane back to align with the magnetic field. Okay, so they want to realign, they want to go back to ground state. And those that were in that initial phase coherence, where they were all at that sort of 3 o'clock, will start to fan out. And they start to fan out because they're different tissue types. So as I said, it might be muscle next to bone, next to ligament, next to fluid. So they all have different precessional frequencies because of that gyromagnetic ratio term. They're not the same tissue types. So they will start to fan out or dephase. So when the RF is switched off, the induced signal decays as the protons return to the state that existed before the RF was applied. So and we talk about this return as being relaxation of the protons. So they're relaxing back to their ground state. Okay? There's two basic relaxation processes. The amount of magnetisation in the longitudinal plane gradually increases. So we can measure over time how long it takes for these guys that are in the XY to go back to the Z. And it's not a long time, it's just in terms of either milliseconds or seconds. So they return back, and we talk about this return to alignment. That's our T1 relaxation. That's how we make a T1 weighted scan. And the amount of magnetisation in the transverse plane gradually decreases, and this is the T2 decay. So this is the loss of phase coherence. So really, really simple, easiest MRI examination includes just T1 and T2 weighted imaging, just in different planes. So for instance, if you were going to have a knee MRI, they'll do a T1 coronal, a sagittal and an axial, and they'll do a T2 weighted coronal and sagittal, looking for bone bruising and tear of ligaments, cartilage disruptions, etc. So again, if we just think about that, that's our magnetic field. Once we take away that RF energy that excited them, they then want to give that off. So here they are, these protons again, spinning, doing all their thing, realigning with the main magnetic field. The way they do that is to give that energy away, the excess energy that we gave them through excitation. They now want to give that off, and that's what we detect as our signal. So conversion of longitudinal magnetisation into the transverse magnetisation results in that initial phase coherence. There's this idea that they're all at 3 o'clock. Okay, so that's this initial phase coherence. As the net magnetisation vector precesses, so it's still under the influence of the main field, as it precesses at the Lamar frequency and dephases with time, after the RF is switched off. So we're just saying that as soon as we take that RF away, they want to give off that excess energy and return back to their ground state. And relaxation results in recovery of that magnetisation or just realignment with the main magnetic field. Okay? Yeah? No, it's all, so T1 is a constant. So the T1 relaxation time of a tissue, so let's say bone, is constant. Okay?
It's not related to what you said at the beginning in terms of the magnetic strength, the T machine, the T1 or T2.
Yeah, so the T1 and the T2 describe, these are physical parameters that are specific to a tissue type. So when we talk about the magnetic field strength as being Tesla, that's not the same as T1. T1 is think of it as T1 relaxation. It's the amount of time that it takes for a tissue that's been excited to realign with the magnetic field. So it's specific to a tissue type. So if we spoke about, say, bone will have a very specific T1 and T2 relaxation time as opposed to muscle. It's different. And it's the differences between those, between bone and muscle, which gives you your contrast resolution. So it's the fact that the tissue types have different relaxation times that allows you to tell the difference between them on images. It's a hard concept to understand, and the best way to think about it is to go and see if you can look at some images. And I can go back at the end and show you, like the ones I showed you with the brain, where you see that T1 weighted, which is why we think about it as being an anatomy scan, they tend to be more similar. So when you look at a T1 weighted scan, there's not a lot of difference between the grey and white matter in the brain. But T2 is very different between grey and white matter. So when you look at a T2 weighted scan of the brain, you can really easily see the difference between grey and white matter. Because you can think the brain as being made up of grey and white matter, they've basically still got neurons and axons in them. It's just a slightly different percentage. And that's why you can see the difference between grey and white matter on the brain. Okay? A hard thing to wrap your head around is the terminology in terms of MR, T1, T2, Tesla, vectors. But if you go back and read it, hopefully it'll start to gel a little bit. And this is, lecture 1, and we'll talk about this, for the next 3 lectures after this. But it might be worth your while just to go and have a look at a text and just try and get that right in your head. Does that make sense?
Yeah, I was thinking if that were the same thing.
Yeah, look, and that's why I showed the video at the beginning. The really, really simple thing is take a person, put them in a magnet, think about how their protons line up. We want to manipulate those protons to go against the field. So we do that by firing radio frequency energy at them. Then we watch how different tissues will react differently because they've got different gyromagnetic ratio and they have different T1 and T2 relaxation times. So it depends on how they give that signal off. That's how we can see the difference between different tissue types. Okay? And that's the simplest MR experiment that you can do. When you go out and start working, there's other contrast mechanisms, but we're not going to touch on those because it's difficult to kind of understand them unless you're there at the machine, hitting the buttons and seeing how they look differently. So the different relaxation results in recovery of the magnetisation to the longitudinal. So remember, we flip them away from the field. We put them into the transverse plane. And as they realign, so giving off energy, emitting RF that we detect, they align back with the main magnetic field. So when we measure that, we can have we can have, so recovery of the longitudinal magnetization is what we describe as this T1 recovery. Okay, and you'll hear people say all the time when they talk about MR, I want you to do a T1 weighted or a T2 weighted scan, and that's what they're referring to. They want you to weight the parameters that you set as the radiographer to reflect the T1 differences between tissue types. Okay, and again, this is what it looks like if we just think about it. Here's our Z, so our Z is the same as our B0, that's how our magnetic field is aligned. This is our net magnetization vector. So this is the sum of all those individual protons. If we fire a radio frequency pulse in, we will flip this net magnetization vector over to the XY plane. So we've now flipped it over here. We wait an amount of time, and the longer we wait, see that this vector that's down here is getting smaller and growing back up this way. Okay, so it's now realigning. And if we wait long enough, it will be all realigned. And the amount of time that it takes to go from here in the transverse plane to back to here is our T1 relaxation time. And that is specific for different tissue types, whether it be grey matter versus white matter in the brain, or CSF, or muscle or bone. Okay? So just look at this. This is before we transmit our RF pulse, here comes our RF pulse. After that, we flip this down here, and then we start over. As time goes on, we see this vector, which is down here, regrow. And it's regrowing because it's giving the energy back. It's going back to its ground state. And the amount of time that it takes for that to happen is our T1. And this is what it looks like. Don't worry about the equation. This is how it tells you how it works. But essentially what we're saying is T1 relaxation time is the time it takes for 63% of the longitudinal magnetization to recover. The reason it's this is just because of this logarithmic equation, this E term. Okay, so T1 relaxation is the time it takes for 63% of it to recover from being XY back to aligning with the magnet. As I said, T1 recovery times, so protons in different tissue types have different relaxation times. So T1 is long in small molecules like water, but it's different in fats. Okay, and remember I said before that when we do clinical MRI, essentially what we're making is a map of fat and water, because that's mostly what we are. Fat, water in muscle, bone, heart, whatever organ you want to think about. And these differences in T1 relaxation times are used to make our T1 weighted scan. So, typically when someone comes in with a request form for a brain scan, show it to the radiologist, and the radiologist will say, I want you to do a T1 weighted sagittal, T1 weighted axial, T2 weighted axial, and whatever else. That's the instructions that you'll receive as the radiographer. You'll then go down and sit in front of the scanner and change some parameters so that that's what you create. Okay? We spoke before about this T2 decay or transverse relaxation. So when the RF is switched off, the protons again give up their energy. They want to go back to their random state. Okay? As the signal decreases, it produces this thing called a free induction decay. Don't worry so much about the terms. It's just another terminology. But the process by which it goes from being in phase coherence to losing phase coherence is our transverse relaxation. And again, it's this 63% loss of transverse magnetization, which tells us our T2 relaxation time of tissue. And they're not linked. T1 and T2 are not linked. There's no equation that links the two. Okay? That's what our FID looks like. This is our signal decaying. And again, it's just this idea that it goes from being a maximum to a minimum. Okay. The only other thing to talk about was this one about T2 star. So T2 star really just brings in this other parameter, which is this idea of magnetic field inhomogeneity. So if I was to say to you, if I had a magnet and I went and measured within the imaging ball within the tunnel, the magnetic field would be fairly homogeneous. But what do you think would create inhomogeneity within that magnetic field, the imaging ball? Us. So inside of us we have air-filled lungs, air-filled sinuses, we have bone, we have fluid, so they introduce inhomogeneities. Apart from other things like metal, so you will still scan people that have had an ACL, an anterior cruciate rupture, they've had it repaired, they may have some metal in there, so they give inhomogeneities too. So what I'm saying is that those inhomogeneities grossly affect the magnetic field and they can give image distortions. So what we're really saying is that this is our main magnetic field. If we have inhomogeneities, they can change the field by a known constant. They can make it slightly smaller or slightly larger. And what happens is that we get images like this. So here's a cross-section here of a pelvis. So here's the iliac wing here, and then ilium over here, and this would be where there's been a hip prosthesis. So because that hip prosthesis has metal, it gives us an artefact like that. Okay, so this is a T2 weighted fat suppressed scan, and you can kind of see, here's our subcutaneous fat. We can nicely see there's different muscles, we can see vessels, we can see bone. Again, we see those because the T1 and T2 relaxation times are different between fat, muscle, bone. Okay, and then here's a brain scan over here, and quite often you see these. This is an artefact that you quite often see with people that have got a lot of metal in their dental braces. So if they've got dental braces and they've got a lot of metal in them, it can make it difficult to do an MR because you get these big artefacts that make the brain distorted and in some cases disappear. So we talk about this T2 relaxation time then being grossly accelerated by the fact of these inhomogeneities, and that's all that the T2 star means. So I would say that the only thing that you really need to remember about T2 star is that it's a combination of the inherent T2 decay, which is specific for the tissue, plus the extra dephasing that occurs because of the magnetic field inhomogeneities. Okay? So what happens is that when you've got the magnetic field which has been affected by these inhomogeneities, is it just makes this dephasing occur faster because the magnetic field is not the same across the whole imaging ball. It's been changed by the fact that you've got different tissue types in there, so it will occur faster. And the important thing to remember is that T2 star is always faster than T2. Okay? So, today we've just spoken about what this net magnetization vector is. It's created by two components at 90 degrees. So we're talking about the longitudinal plane and the transverse plane, and how we flip our net magnetization vector at rest. So when we first take someone in at rest, we push some of those spins into the transverse plane. We energise them, push them into the transverse plane. We then wait for them to go back to ground state and measure how they give that extra energy off. We measure that in two ways, T1 and T2, and that's how we make our images. So before resonance, there's full longitudinal magnetisation is parallel to the main magnetic field, the B0. After the application of a 90-degree pulse, depending for how long and for what magnitude, we flip it. Okay, so once we flip it into the transverse plane, once we remove that, we see it recover. It wants to go back to ground state. And it does that by two processes, T1 relaxation and T2 relaxation. There's definitions for both of those. So it's recovery of the longitudinal magnetisation. Yep. Why aren't they linked? Because they're different processes. So one of them is about, so it's about how the energy is given off. And it all goes back to chemical structure. It's about, some of them will give them off to molecules next to them, and some of them will give them off to spins or electrons next to them. But that's really getting into chemical processes. And sometimes you will see that these terms are also referred to as spin lattice, so that's our T1, or spin-spin relaxation, and that's our T2, where they're giving the energy, because they can't just emit it to nowhere, they have to give it to a neighbour. So depending on how they give it off, if they give it to surrounding molecules or surrounding electrons, that's the difference between T1 and T2. But they are specific for a tissue type, and they're not linked because it occurs in a different way. So they're not giving it off in the same way, they're not giving it to the same molecule or the same part of an atom. Okay? And that, I mean, those terms come from chemistry, and that's how this started, but what we're doing as clinical MRI is not the same as what they do in chemistry. Same physical processes, but they're interested in looking at chemical structure, we're interested in looking at the structure of humans. It's probably the easiest way. If you want to know more, we can talk about it, but probably not, not for general consumption. Where was I? So T2 relaxation is the loss of that transverse magnetization due to interactions between magnetic fields and adjacent nuclei, which is this concept of talking about how it gives the energy off to adjacent nuclei or adjacent electrons. And just knowing that the transverse component is decaying. That signal then induces a voltage essentially in a receiver coil, and it's that reconstruction of that image or that signal which allows us to create our MR image. So for instance, as I said, in chemistry, they're not interested in creating an image like we are of humans. They're more interested in identifying a chemical structure. Any other questions?